Good afternoon, everyone. My name is Ayodele Jegede. I'm a professor of medical sociology, anthropology, and bioethics, and I'm the current director of a research management office at the University of Ibadan. I welcome you to this workshop on this virtual workshop on the health of women, newborns, children, and adolescents in conflict settings in West Africa, improving evidence and the guidance for effective action, which is jointly hosted by the Bridging Research and Action in Conflict Settings for the Health of Women and Children, BRANCH Consortium, the Partnership for Maternal, Newborn, and Child Health, the University of Ibadan, the CPICS Center for Global Health. This meeting is convened to address important issues confronting our society today. We are not unaware of the menace created and still being created by conflicts in different regions of the world, and especially in the focus region for this meeting, especially on how it affects the target population. The target population. So, human capital is an important ingredient for development, and women and children constitute the important source of this renewable resource. Renewal of a human resource is being challenged daily by conflict in many places, and therefore makes it difficult to address issues relating to procreation, such as issues the area of reproductive health, sexuality and sexual health, women and children health and nutrition. For instance, rape has been reported in many conflict contexts, while issues of food insecurity is a major problem affecting conflict-ridden communities, with women and children most affected. All these constitute hindrances to the attainment of the sustainable development goals and rob the world of the gains of the Millennium Development Goals. To address this challenge, this webinar aims to reflect on what the branch evidence tells us about progress and challenges in responding to women, child, and child health needs in conflict settings in Nigeria and Mali. 2, to identify factors contributing to or hindering collaboration, accountability, evidence building, and advocacy for effective women and child health plans and programs. 3, to discuss how to leverage the available branch evidence and experience to strengthen linkages across disparate stakeholders groups working on issues across the continuum of care for more responsive evidence-informed policy, financing and action for women and child health in conflict-affected regions in Nigeria and in Mali. And lastly, to develop a set of advocacy actions building on branch recommendations and the relevant aspects of the PMNCH COVID-19 call to action, and to drive responsive policies and strengthening response and programs for WCH conflict settings in West Africa and Africa. It is expected that this webinar will lead to increased knowledge and understanding of the participants on the existing evidence and gaps, what works and does not work regarding implementation and the issues that need to be addressed to respond to WCH issues in conflict affected context in regions. Two, to strengthen alignment among the participating stakeholders. Group's priority next steps for further evidence and policy change. Enhanced multi-stakeholder collaborations, joint advocacy, and improved implementation around the WCH in conflict-affected context in the regions. Three, to develop the development of a list of advocacy actions for each participating country or region, additional evidence and knowledge translation tools. For instance, policy briefs needed to support evidence-based advocacy efforts and action for more responsive policy around WCH in conflict-affected context in the regions. Moving forward. Ladies and gentlemen, I welcome you all to this webinar and request for active participation, especially during the breakout sessions, so that your views will count in harnessing solutions to this challenge. Furthermore, it is important that I highlight the following to all participants. First, there is a translator button on the bottom right side of the Zoom meeting middle. It is called interpretation button, which English speakers should choose English, and French speakers will choose French, because this is a bilingual meeting. Secondly, if you have questions, you could put it in the chat box on the Zoom platform.
I think Professor Jegede, you have frozen.
Yeah.
But we were just, I think, coming to your final housekeeping instructions about adding questions to the chat box.
Up, your camera.
As I think Professor Jegede is still frozen.
Window.
Michelle, why don't you make the
announcement? Okay, great. So let us, until we get Professor Jegede back, that was just the housekeeping about the interpretation button for English or French language interpretation and adding questions to the chat. Again, just before we start the presentations, I'll just ask people to look in the chat where there are instructions about updating your name of your profile, changing it from Michelle or Maher to your own name. But beyond that, let me just, I think Professor Jegede was about to hand over first to Dr. Butta and then to Dr. Langlois for some opening remarks. Zulfi, I think we will, Professor Jegede was going to ask you just to say a few words first, if you would, of welcome on behalf of Branch, and then we'll have Etienne Langlois give some opening remarks on behalf of PMNCH as well. Just a minute, Zulfi, just 1 or 2 minutes, thank you.
Oh, that's fine. I can be even shorter because we are running late. So on behalf of the BRANCH Consortium, so Bridging Research to Action for Maternal Child Health in Conflict Settings and Humanitarian Crises, I welcome you all to this workshop. This is our third workshop in the series of discussions around products that I will very shortly be sharing with you, and some discussion around how to practically implement things. But without taking further time, let me pass the floor to Etienne to welcome you on behalf of the PMNCH. Etienne, floor is yours.
Thank you very much, Zulfi. Etienne Langlois, the team lead for knowledge at the Partnership for Maternal, Newborn, and Child Health. I'm delighted to be here and to introduce this workshop. So I have a brief presentation that I will make in French. So for those who want to listen in English, please click on interpretation and select English moving forward. Next slide, please. So, la présentation est sur l'utilisation de l'évidence scientifique pour la prise de décision contextualisée à l'Afrique de l'Ouest. On a un accent sur le Mali, sur le Nigeria pour cet atelier. C'est le troisième atelier qu'on fait pour avancer la question de la santé des mères, des nouveau-nés et des enfants en zone de conflit. Le premier était en Afghanistan, Pakistan au mois d'août, le deuxième au Moyen-Orient en septembre. Et là, on a le plaisir d'être ici avec vous pour cet atelier sur l'Afrique de l'Ouest et les défis contextualisés à la région. Alors, quelques mots sur PMNCH. On est l'alliance mondiale la plus importante pour la santé des mères, des nouveau-nés, des enfants et des adolescents. On a plus de 1200 partenaires distribués dans 192 pays. On a une stratégie pour 2021-2025 qui priorise la santé maternelle, santé néonatale, santé infantile, mais aussi santé et droits sexuels et reproductifs, ainsi que la santé des adolescents, la santé et le bien-être des adolescents. Donc, c'est vraiment une action qui se fait au niveau du continuum des soins pour ces populations, au niveau de l'intégration des soins et aussi au niveau de la qualité des soins. De plaidoyer. Alors, c'est un plaidoyer qui est basé sur l'évidence scientifique, basé sur les données probantes. C'est pour ça que notre partenariat avec le consortium BRANCH est si important, si pertinent. L'enjeu est vraiment d'utiliser des données probantes contextualisées pour informer la prise de décision. Alors, next slide, please. If I can please ask everyone who is not on mute to please mute yourself. Travaille à PMNCH avec 10 groupes de détenteurs d'enjeux différents. C'est vraiment une valeur ajoutée de PMNCH d'amener tous ces acteurs ensemble dans des dialogues politiques, des dialogues multisectoriels. On travaille avec le milieu académique, bien sûr, mais aussi les associations de professionnels de santé, les Nations Unies, le secteur privé, les organisations de la société civile, et on amène tous ces acteurs à discuter ensemble de solutions communes pour des défis qui sont très complexes autour de la santé des mères, des nouveau-nés et enfants et adolescents. Prochaine diapositive, next slide, please. Alors, on a une priorité sur l'équité et ça se traduit en fait dans un portfolio sur les contextes humanitaires, les contextes très fragiles qui incluent évidemment les zones de conflit. Alors, on travaille beaucoup sur cette question d'approche multisectorielle, intersectorielle. On travaille autour de la synthèse des connaissances, l'application des connaissances. On vient, par exemple, de compléter une revue systématique sur les soins de sages-femmes dans les zones humanitaires avec des données probantes du Nigeria et du Libéria, entre autres. Et on fait aussi beaucoup de renforcement des capacités. Alors, on attribue des subventions à des partenaires sur le terrain. Par exemple, au Nigeria, on supporte le Africa Health Budget Network pour le plaidoyer, pour la reddition de comptes, pour le accountability. Alors, ça, c'est un des exemples de support qu'on a au niveau du pays. Idem pour des plateformes de collaboration multisectorielles et ça, on supporte de telles plateformes au Libéria, au Nigeria et au Zimbabwe. Prochaine diapositive, next slide, please. Alors, je parlais de l'utilisation des données contextualisées. C'est très intéressant de voir les études de cas qui ont été faites par BRANCH au Nigeria, au Mali. Et ici, on a quelques données qui proviennent de ces études de cas qui vont être discutées pendant l'atelier. Donc, par exemple, on sait qu'il y a une pénurie de travailleurs de la santé, surtout des femmes au Nigeria. Il y a une question de manque de qualification professionnelle, de formation continue. Au Nigeria encore, la question des environnements, de la sécurité dans laquelle opèrent les professionnels de santé. Ça a été documenté au Mali. Ça a un impact évidemment sur le recrutement et la rétention des professionnels de santé. Puis je pense aussi on a, nous, comme communauté, une obligation de protéger les professionnels de santé. Si on regarde les dernières données sur la vaccination contre le COVID, par exemple, on voit qu'il y a seulement un travailleur de la santé sur 4 sur le continent africain qui est pleinement immunisé contre la COVID. Donc, c'est un constat qui est inacceptable. On le voit aussi avec les répercussions du nouveau variant. Alors, c'est quelque chose qui est vraiment un défi qui doit être adressé urgemment. Prochaine diapositive, next slide. Et ça, donc, je termine là-dessus, entre autres sur les enjeux qu'on va discuter pendant l'atelier, la question de coordination des actions par les différents détenteurs d'enjeux, la question aussi d'utiliser l'évidence scientifique pour informer la prise de décision, ce qui est un défi. Hein, on le voit au Nigeria, par exemple, ça a été documenté, comment prendre des décisions éclairées basées sur des données scientifiques quand on manque de données. Donc, la question de renforcer les systèmes de données, les systèmes d'évidence scientifique. Et aussi le dernier enjeu, celui du financement de la santé, donc financement durable, financement basé sur les besoins. On voit que ça a été aussi un enjeu au Nigeria et au Mali, et aussi la question du manque d'adaptation des programmes de financement, encore une fois documentés au Mali. Donc, tout ça, ce sont de grands défis sur lesquels on va se pencher pendant l'atelier et je pense qu'ensemble, on va trouver des solutions pour améliorer cette coordination, améliorer l'action pour la santé des mères, des nouveau-nés, des enfants et des adolescents. Merci.
Thank you very much, Etienne. I'm not sure if we have Professor Jigade back.
Yes, I'm back. Hello.
Hi, Professor Jigade. So if you'd like, we'll move into the first session now okay. on the branch findings. And so Zulfi Bhutta, Zulfi, you'll be presenting first and effectively chairing the session. So please go ahead, Zulfi. Let's get started.
I just want to make sure that you can see my slides. And
we see them in speaker mode.
I will change that. So thank you very much for the opportunity and for giving us time. And it's really heartwarming to see so many people turn up for this workshop, largely because it's an issue so close to people's hearts. So I'm Zulfi Bhutta. I'm the chair in Global Child Health and Policy at the Hospital for Sick Children in Toronto, and I also direct the Institute for Global Health and Development across Aga Khan University campuses in Africa and Asia. So I want to principally summarize very briefly the context of this particular series in the Lancet and the body of work, and then my colleagues Anushka Talajan and Michelle Gaffey will respectively take you through some of the findings. Over the next 10-15 minutes, this summary will provide you a little bit of the background of the scholarship and how it should be the beginning of a dialogue and a discussion around many of these issues. So the BRANCH Consortium is an academic research enterprise which focuses on trying to understand and do something tangibly for improving the evidence and guidance for effective action on women and children health and nutrition in conflict settings. We have, in addition to the core group of investigators, an international steering committee, and build a lot of our work and scholarship around collaboration with global advocacy agencies, such as the PMNCH, which is a phenomenal partner, and also many of the UN agencies that have been involved as part of this process and bilaterals. So the core group members are highlighted on this particular slide, including some of the leading universities in high-income countries, but they're also supported, as I said, with a lot of groups, including the Countdown, PMNCH, as I've mentioned, UN agencies, and a large number of in-country partners. So we are very proud of this consortium, which includes now increasingly leadership and people in the South, such as our colleagues at the University of Ibadan, who are hosting this workshop with us jointly, and also colleagues from Mali who have joined us today. And this collaboration has been largely focused on dissemination and advocacy around some of the work. So our activities largely started because we felt 5 years ago that there was a major global gap. While there were actions underway, there was a gap in understanding the numbers, the estimations and distribution of RMNCH-related mortality and morbidity that could be either directly or indirectly attributed to conflict. There was not a clear external evaluation of existing guidance and normative documents that were helping policies and NGOs who are in the field. And to do this, we said we would have a very deep dive of the literature. That took us almost 2.5, 3 years to look at what was available in scientific publications and also in gray literature. But we were not satisfied with that alone. And in addition to all of that, we also undertook a number of in-depth country case studies to understand from partnerships and work on the ground as to what was happening out there. And this was also then associated with a delineation of where the gaps were, what were the research issues that were coming forward, and importantly, such as today, how could we implement and take things forward in the future? So the systematic reviews that have been undertaken as part of this exercise have focused on the country case studies, and they appear in Conflict and Health. They're all open access, and they look at country case studies across 10 countries. We also have a full series of systematic reviews in the BMJ, looking at the evidence base for interventions across a range of direct and also potentially indirect interventions for women and children and reproductive health. But the core and the crowning work was published in the Lancet as a series of papers and comments earlier on this year as a 4-part series that I will be going through shortly. So the Lancet series consisted of these 4 papers and 1 linked comment. The papers explored both the background, the political and security dimensions of conflict and humanitarian emergencies, the direct and indirect effects of conflict on women and children, and what needed to be done to deliver this better in countries through the case studies. And then what Dr. Gaffey will talk about is how do you deliver these and what is the evidence around implementation of these interventions in women and children setting. And finally, how can we do better? And that's something that I might address in the closing sessions of this workshop. So we start by looking at how the context may have changed over time in terms of our knowledge of conflict effects on women and children. This paper was led by Paul Wise from Stanford, and a large number of authors who contributed to this understanding. So the paper makes a large number of important points. One is that the nature of warfare and the nature of conflict over time has also changed. And from a pattern of intrastate conflict, we are increasingly now looking at intrastate, hybrid kind of conflicts with a large overlay of terrorism and also insurgency. And it is sometimes in many conflicts very difficult to differentiate the good from the bad. And also importantly to note that partly because of better reporting, that the patterns of violence, particularly sexual violence in many of these conflicts has also become quite apparent. There are, of course, associated humanitarian risks, both to the health system, to food supplies, to population displacement, leading to both direct and indirect effects, which will be the subject of much discussion. What Dr. Wise also talked about was that this is a dynamic field, that this is changing all the time. And again, in terms of the response, we also now increasingly see that some of these sacrosanct areas in conflict, such as health workers and other humanitarian workers who were largely protected under the Geneva Convention, have now increasingly also been targeted by combatants in some of the more recent conflicts. Again, a very egregious development because it does lead to a very direct impact on what can be provided as services. COVID-19, the last 2 years almost, have been a global disaster which has no parallel. The whole world has been affected, both in terms of its ability to respond to many of these challenges and also the need to contain this pandemic with mitigation strategies that have had an impact on how we deal with humanitarian crisis. And the third point that Dr. Wise makes is that there needs to be the nimbleness, the rapidity of response in many of these circumstances that is currently lacking, both in terms of resources, also in terms of our ability to respond readily in many humanitarian settings, and it takes a lot of time. Afghanistan is an example. We've been seeing this slow train wreck for the last several months, and yet action on the ground to address the humanitarian needs of people who are very soon going to be at major risk of food emergencies has been very slow to get off the ground. Let's talk about numbers. And Dr. Iran Ben David and colleagues from Stanford worked as partners in looking at the effects of armed conflict on the health of women and children. And they built on previous work that had been done, particularly in Africa, through geospatial assessment of how conflict related to mortality for children, published in the Lancet in 2017, and on women, maternal deaths in relation to conflict. And the point that was made was that between 1995 and 2015, there have been close to 11 million deaths or more of women and children in Africa that could be attributed to the direct and indirect effects of conflict. I mean, it's a massive number, much greater than what people had thought previously. The other point that they made was that there is a very clear relationship between severity, chronicity, and the distance of conflict on infant mortality. And the same can be applied to newborns, same can be applied to maternal. And as you can see, as the severity of the conflict increases, there is not a linear, but perhaps an exponential increase in the risks of mortality and change in numbers for children. And also the longer the conflict, this is not cumulative, this is additive risk of dying in those circumstances. And they also, very importantly, produced evidence that there was a ripple effect, that we saw, of course, the highest burden closer to the epicenter of the conflict, but there was excess risk of mortality, even if you went 50 to 100 kilometers beyond where the conflict and conflict-related events were located. And all of us have intuitively known this, but this is important to recognize as a quantification of the excess risks and mortality in these circumstances. And the end result of all of this is that the estimates, particularly for Africa, showed that between 1995 and 2015, the indirect effects of conflict was significant, and that these conflict-related mortalities were significantly greater than the direct causes of death from armed conflict. So indirect impact on the health systems and on the health of women and children was quite considerable. Well, Africa is not the only place in the world with conflict. And as you can see, conflicts have affected various parts of the world, and this is a chronology of conflicts and their distribution over time: Latin America, South Central Asia, where I come from, and parts of South and Southeast Asia and the Middle East sector. So you can see the distribution has affected almost all the countries in the proverbial South. And the same risks that you talked about in terms of distance and mortality are quantified in terms of percentages here in various geographies. So you see this in Asia, Africa, America, and the relationship stands robust. It's much greater, of course, in Africa, which drives the overall estimates, but it is notable all over the world. So the key messages from this work were, number one, that this is a huge global problem, and it is increasing. And it's increasing as a combination of increased population size, the urbanization of a lot of conflict, which of course has greater population density, and also a steady increase in conflict events across the world. I mean, the estimates at the time when this was published was that there were over 600 million women and children, almost 10 to 15% of the entire population who were either displaced by conflict or resided dangerously close to armed conflict events. And the mortality risks, as I've mentioned, are very proportionate to the severity and the chronicity of the conflict. And as I've mentioned, the numbers are massive, more than 10 million deaths. The way the health is affected by conflict is through a wide variety of things, including malnutrition, physical injuries, infectious disease access, but importantly, things that we have not yet spoken about in public or done anything about, mental health. And it's important to recognize that although sexual and reproductive health has been under the focus for a number of years, action on the ground for this has been relatively slow. But many agencies have worked on this, and that work has got to be recognized, including IWAG. The evidence around some of these impacts are generally not easy to find. You can find data on battle-related deaths, but the indirect effects of conflicts are very, very sparse. And in some age categories like adolescence, the data is almost non-existent. So I'll stop at this stage and pass the floor to my colleague, Dr. Anushka Talajan, who will tell you a little bit more about the country case studies. So Anushka, the floor is yours. I'm happy to move your slides.
Great, thank you. So what I'm going to share now is some insights from a collection of 10 country case studies that aim to understand the delivery of sexual, reproductive, maternal, newborn, child, and adolescent health and nutrition interventions, and what we will hereafter refer to as women, children, adolescent health. I'd like to first acknowledge that this work is really collaborative work by several different authors, and was led by my colleagues Neha Singh and Carl Blanchet. And we had a collection of 82 researchers from 24 institutions that contributed to this work. And that included colleagues in Afghanistan and Pakistan, Colombia, DRC, Mali, Nigeria, Somalia, South Sudan, Syria, and Yemen. Next slide, please. So before I share our findings, I want to give you more details about our methods. And our work was informed by secondary quantitative data and primary qualitative data. And we described the coverage of key interventions for women, children, and adolescents, and then also focused on explanatory variables, which were underlying the variability in the delivery of health interventions, particularly focusing on assessing decision-making processes, obstacles to implementation of proven women, children, and adolescent health interventions, and the adaptation of service delivery strategies to address the needs of women, children, and adolescents in different geographic, political, economic, and environmental contexts. Next slide, please. So I'm going to share a quick preview of our results. And we know that national and international organizations, governments, and other humanitarian actors face many obstacles when delivering key interventions. So for our study, we adapted the WHO health systems building blocks to develop humanitarian and health building blocks, which included the domains in the column on the left. And we use these to dive into the bottlenecks that are experienced by different countries. I encourage you to take a look at our paper that has more details on these different bottlenecks if you want further information. Next slide, please. So we also assess the creative solutions that humanitarian actors have employed to overcome barriers to implementation. And this table summarizes this information. And just for a quick overview, we found details related to strategies such as remote management, the use of pooled funds, localizing healthcare, and rebuilding trust with communities. Next slide, please. So our key messages here were that we found that despite very large variation in context and decision-making processes, services such as antenatal care, basic emergency and obstetric newborn care, IYCF, and maternal malnutrition screening and treatment were prioritized. This was in contrast to other life-saving services, such as the majority of sexual reproductive health services and newborn adolescent health services that weren't prioritized. And services to address stillbirths were still markedly absent. We found that donors still played an important role in determining which services were delivered and how these were delivered. And our study also highlighted the importance of increasing consensus on priority predefined packages for women, children, and adolescent services. And I believe my colleague Michelle will speak about this in a moment. Next slide, please. We found that working within the political governance system posed a specific challenge, especially when working in areas with non-state actors. And our study also demonstrated that the humanitarian system is dynamic and responsive to the different contexts, and that humanitarian actors had found innovative and creative solutions to operate within the challenging environments that they were working within. We also demonstrated that it was critical to recognize the role and importance of local actors and really their critical role in ensuring the success of the delivery of services and ensuring that they have the funds allocated to them and the decision-making ability to be able to pivot as needed. Our study highlighted the importance of centering the voices of those who are affected by humanitarian settings. And just to conclude, I want to note that although it is our ultimate goal should really be to decrease the number of conflicts and the amount of people that are affected by conflict globally, that until that stage, it is absolutely essential that we are ensuring that individuals are having their health and nutrition needs met through the delivery of services. Thank you.
Over to you, Michelle.
Thanks, Nishka. Thanks, Zulfi. So I'm talking here about the fourth paper in this series, and let me start by acknowledging the co-authors on this paper, which include colleagues formerly from WHO, as well as from Save the Children, the International Federation of Red Cross and Red Crescent Societies, the International Rescue Committee, MSF, and the Emergency Nutrition Network. So this paper evolved from two other work streams, and Zulfi mentioned them both in his talk. One is a set of systematic reviews of the literature on intervention delivery for women and children in conflict settings. And the other was a systematic assessment of the existing global guidance relevant for women and children in conflict settings. So the findings of both work streams, which we've published elsewhere, underscore that there is still a very limited availability of evidence and guidance that is specific to conflict settings. And that led us to think about what we could do or what could be done sort of now in the short term to help fill or at least bridge that guidance gap. So what I'll briefly outline here is the decision-making framework that we developed, and also how we piloted this framework by applying it to a set of hypothetical conflict contexts. So on the screen here now is the decision-making framework, and step one of the proposed framework focuses, not surprisingly, on the assessment of needs among women and children in a given conflict setting. So in order to determine which health and nutritional conditions should be targeted for intervention. Step two, the next box, is then to identify those interventions that, if they were implemented, would address the assessed needs. So these interventions should then be considered potential priorities for delivery. And then step number three is to assess whether and how each of those interventions identified as potential priorities in step two could actually be delivered in the given setting. And that's considering the prevailing levels of insecurity and the human and material resources available in a given setting, as well as any other local factors that could affect intervention delivery. Next slide, please, Zulfi. So this is the our conceptual framework that we used. We piloted our proposed decision-making framework by applying the framework in the previous slide to a set of hypothetical conflict contexts. And to define those contexts, we used this framework, this conceptual framework. And BRANCH used this conceptual framework, developed it early on to help guide our thinking about intervention delivery in conflict settings. So this conceptual framework broadly classifies conflict-affected areas and populations in terms of their exposure to active violent conflict, and then by extension, their access to health services. So in the very center, populations located in conflict epicenters we classified them or considered them as presently experiencing acute active violence, and so population mobility and therefore access to and by health workers is severely restricted, if even possible. The next kind of area moving out from the center, insecure areas, are those where the threat of attack might be imminent, but the population is not presently exposed to active violence. And so mobility and access to health services may actually be unrestricted, even if only temporarily through the negotiation of humanitarian space. And then sort of the outermost ring, the stable areas, are those that we classified as those in which displaced populations have settled in relative safety, either in camps or dispersed within their host communities. And they generally have ongoing access to health services. Next slide, please, Sophie. So we then applied the decision-making framework to each of the three hypothetical conflict contexts. And by doing that, we then identified a set of illustrative packages of priority interventions for each context. So first of all, thinking about burden in each of the three areas, we used a simplifying assumption that there would be a high burden of a wide range of health and nutritional conditions among women and children in all three of our hypothetical contexts. And then in step 2, in terms of identifying potential priorities for delivery, we compiled a set of 77 evidence-based interventions that would address the wide range of conditions that we identified in step 1. And that set of interventions that we identified draws from those interventions that are already recommended in key sources of humanitarian guidance, the handbooks and guidelines and toolkits that are already out there that are focused on humanitarian guidance, on humanitarian settings. Plus, we added a small number of additional interventions drawn from the non-humanitarian guidance. So for step 3, to then identify, sorry, just back one, Sophie, to identify which of those potential priorities could actually be delivered in each setting, we met in person, we convened an in-person meeting to discuss whether each of the 77 interventions could actually be delivered in each of the hypothetical contexts. To determine this, we considered the lowest level of care at which each intervention could be appropriate delivered. So whether that was in the community, sort of the lowest level of care in the community, in primary care facilities, or at the hospital level. And then we tried to figure out whether each of those levels of care would likely be available in each of the contexts that we were considering, given their varying levels of insecurity. So the results are detailed in the paper, which I'll refer you to, but just very briefly, for the epicenter settings, in the context of active violence, we ended up prioritizing only 17 urgent life-saving interventions for those areas where violence is acute, and so the personal safety of care providers and care seekers would often outweigh the imperative actually to provide the comprehensive services. In the next setting, the insecure areas, we found that a much wider range of interventions could be implemented. And there we identified 74 of the full set of 77 that we think could be prioritized for insecure settings. And then finally, the full set of 77 interventions we considered priorities for secure areas, camps or internal displacement camps or refugee camps, or areas in which displaced people were being hosted in host communities. So some key messages then to conclude on the last two slides. First is that we recognize or found that evidence-based guidance for women and children on health and nutrition in conflict settings specifically is very limited, and it's needed in order to think about what should be prioritized in these very specific humanitarian settings as opposed to humanitarian settings broadly. And as a preliminary step towards filling that guidance gap for conflict settings, this decision-making framework explicitly takes conflict context into account. And we propose by applying the framework, could improve response effectiveness and perhaps also accountability for the decisions that are made, because those decisions are made and the priorities are set in this seemingly objective way. And then finally, last slide, Sophie, please. Ultimately, that in a given conflict setting, it is effective interventions that address local needs and that can feasibly be delivered, which should be prioritized in a given setting. And that's what this paper tried to lay out. Okay, so that's it from me. Thank you, Zulfi. Back to you, I think, for a few more slides on KT.
Thank you. So we are now in a knowledge translation mode, is to take all of these academic papers and translate them into practical steps that can be done in the field. And today's workshop is an example of how we are trying to do that by engagement and discussion with people who are actually working on the ground and are the users or utilizers of a lot of this information. So we are very grateful that as part of this exercise, PMNCH came forward and has offered us a platform of webinars utilizing the opportunity during COVID-19. But in the future, we hope that some of these can also take place either in a hybrid or in a virtual mode. So we are dealing also now with additional emergencies, and therefore some of the discussion is also now looking at conflict settings and the impact of COVID-19 within this. With PMNCH, we have produced a range of knowledge briefs and advocacy documents and toolkits, and I would urge you all to look through these. They are freely available on the PMNCH website, and they deal with a large number of issues related to conflict settings, human resources, their deployment, and also on the evidence-based interventions around the entire continuum of women, children, and adolescents. This is the third in our series of workshops. The first one was held to cover the Afghanistan-Pakistan sector. The second one, the Middle East, where we partner with American University in Beirut. And this third one, which is by no means sufficient in terms of covering the entire continent of Africa, is looking at the beginning of a dialogue in Africa around what needs to be done in this space. And we realize that we need to do one in the Horn of Africa also at some stage in the future. So thank you very much for your attention. I'd like to once again thank PMNCH for its partnership here and acknowledge that this is not just work of our center here in Toronto, but the work of the entire consortium, which has spent years now trying to build this evidence base and the basis for this discussion. And we look forward to listening to you and learning from you in the course of this workshop. Thank you very much for your attention.
Thanks, Zulfi. For the end of this session, we'll invite now, and I'm happy to introduce Professor Donnelly and Dr. Samake, who will hopefully give us some reflections on the relevance of the series for their particular country contexts, Nigeria and Mali. So let me start by introducing first Professor Donnelly. Patricia Donnelly is a professor in the Department of Biological Sciences at the University of Maiduguri in Borno State and holds various certificates in the areas of gender, sustainable development, good governance, conflict management, and monitoring and evaluation. She is a gender activist who consults for both national and international organizations and is the immediate past chair of the board of WANEP Nigeria, the West Africa Network for Peace Building. She's also currently the executive director of the Gender Equality, Peace and Development Center and chair of the board of Action Aid Nigeria. So Professor Donnelly, if you want to take a few minutes and give us your reflections, that would be great. Thank you. Over to you.
Thank you very much, Michelle, and thank all the presenters for the findings of the various research that we're undertaking. As I was listening to that, to all the presentations, of course, this resonated very much with me in the area of the northeastern part of Nigeria. As you are all aware, the Boko Haram insurgency has been on now since 2009, and the areas that have actually suffered the worst are the areas of education and the health facilities. In northeastern Nigeria, about 788 health facilities have been destroyed by Boko Haram. About 48 health workers have been killed and 250 injured. In Borno State, about 40% of the facilities have been destroyed, and about 1/3 of the remaining is the only one that is functional. And this takes us to the impact, of a Boko Haram conflict on health, which is our focus of discussion today. the implication of the destruction of the health facilities and the death of the health workers. Actually, what we are talking about today, some of the findings from the study was the accessibility of service delivery to the various areas where the needs are required. Another thing that I had from the discussion coming, which also resonates with me, is the fact that more people have actually died as a result of the indirect causes of the conflict than direct causes. UNICEF actually said about 350 people have died of the Boko Haram crisis in northeastern parts of Nigeria. But 314,000 of those actually died from indirect causes. And they include women, men, children. More men have died as a result of the direct causes of the conflict, and more women and children have died as indirect causes of the conflict. And a lot of those deaths actually arise as a result of malnutrition, especially among the children. At one stage, I think in 2017, the governor of Borno said the children are just falling down and dying like flies because there was no food. And of course, the issue of food insecurity is actually understandable. When you look at the fact that due to insecurity, people are not able to go to the farm. Borno State or the whole of Northeast is actually an agrarian society where they depend on agriculture. But you find that because of the insurgents, people are not able to go to the farms. And so livelihood and food insecurity has continued to be on the increase. And because people are not able to go to farms, another implication is the fact that the prices of food has also gone up. That means the purchasing power is not there for the people who have lost their livelihood. And of course, this has a linkage to malnutrition of the children. The northeastern part of Nigeria actually has one of the worst indices of socioeconomic indices in part of Nigeria. We have the worst maternal mortality rate, which is the highest in the country. We have the worst unemployment. We have the highest rate of children that are out of school. So Boko Haram came and exacerbated all these factors. And so you find out that at one stage, about 2.4 million people were displaced into various states and outside of the country. And even in the camps where they have been displaced, there's a lot of overcrowding. And the implication of overcrowding is about disease outbreak. So we find out that there are sporadic breakouts of cholera, within this camp. Another thing that is a problem, and which maybe the paper was a bit silent over, is the health problem, is the issue of the sexual gender-based violence, which is very, very high. And this is something that we hardly tackle, or when we touch it, this is just a tip of the iceberg. First of all, the health structures, the health facilities have been destroyed. Where do we then take these children? Case management can only deal with a few of the ones that are available. We have a few staff or sexual assault referral centers within the country. For the whole of Borno State, we have got only one. Adamawa, we have one, and I think Yobe, we have got two. This is just not enough to provide the services that are required, especially when a woman has been raped. And the issue of rape, the prevalence of rape is so high within the northeastern part of Nigeria. At one stage, between January and April, I think it was 2019, over 66 women had already been raped, according to the police report. But of course, if 66 people were reported as being raped, it means that there are a lot that have also gone unreported. In fact, we are told that of one case that is reported, about 3 cases go unreported. So we need to tackle the issue of sexual gender-based violence. And I think the paper was a bit quiet on that. And that leads me to the issue of the mental health. Because of sexual gender-based violence and the trauma, there is a lot of mental health problems within the various camps. And I'm restricting myself to the camps. I'm not talking about the host communities. So you find that a lot of women are into drugs, of various types of drugs, to ameliorate the impact of the trauma and what they have suffered from sexual gender-based violence. And when we also talk about sexual gender-based violence, We're also talking about issues of sexual exploitation and abuse, where people who are supposed to make provisions for these women take advantage of the women and tell them unless they give their bodies, they are not ready to give them what is meant for them. So there is a lot of sexual exploitation and abuse, a lot of stigmatization, a lot of ostracization, especially for the women who may have been associated one way or the other with the Boko Haram insurgents. So we have all these problems in the camps. And then we find out that we have very little places where we can provide psychosocial support for these women. A lot of organizations have come up with issues of women and girls safe spaces. But then the problem is how many of them, there are many, 80% of the camp population are made up of women and children. And a lot of the girls are also victims of rape, early marriages, and other forms of violence against women and girls, especially issues of also female genital mutilation. And of course, we are all aware that during the COVID-19 pandemic, sexual gender-based violence actually become a shadow pandemic, you know, where there was a lot of issues of gender-based violence, either by intimate partners or by various people within the communities because of the lockdown. And during the lockdown, there were also problems of how women who had issues, mental issues, gynecological issues, rape issues, how they were unable to access health facilities. We found out that even the workers, humanitarian workers, did not have access to those things because there was a complete lockdown unless you had a ticket from the government for you to be able to go and report a rape case or a woman who has been raped and so on. So there were issues, and issues of women were deprioritized as COVID-19 came to the forefront of the global agenda and community agenda. And again, on the issue of I'll take it one by one. I may be a bit disjointed, but I'm sure you'll get some points. Also, the issue of immunization. Immunization is key, you know, to issues of childhood ailments and all those ones. But we found out that during the Boko Haram crisis, a lot of the healthcare workers were afraid to go out, you know, to provide immunization services for the children. And this is understandable because sometimes at the early part of the Boko Haram insurgency, some healthcare workers who went into Kano to provide immunization services were killed. You know, so their fear is actually not unfounded. So that also became an issue, you know, for the health workers. And then an area I quickly want to touch is the fact that it appears as if because of the close hours or lack of things to do, the women's fertility has actually increased. And we are finding ourselves having women having many children, multiple pregnancies, and having so many children. So the average of a household number may be about 10 children per household. And having getting pregnant, multiple pregnancies in an area where there are no health facilities, because most of the camps do not have health facilities, or where there are no gynecological doctors to provide the services, becomes actually a high risk for the women. And that is why I spoke earlier on that the maternal mortality is quite high, and even within the camp. And in the past few months, a lot of the women that we are working with have actually lost their lives as a result of a risky pregnancy.
Professor Donnelly.
Yeah.
Thank you very much. I think we need to wrap up this particular your particular talk, but thank you so much. That's very interesting and sobering reflection on linking what you just heard about the BRANCH findings to the situation, particularly in the northeast of Nigeria, including the huge indirect effects of conflict on the population, and of course also how those indirect effects have been amplified or rather exacerbated by the COVID pandemic and the restrictions thereof. So thank you very much, Professor Donnelly. That was great.
Thank you.
Thank you. Let us move on now to one final reflection in this session from Dr. Salamata Samake from ACF. So Salamata is trained as a medical doctor and has been working with Action Against Hunger, or Action contre la faim, in Mali since 2011. And Dr. Samake is currently ACF's Health and Nutrition Coordinator in Mali. So Dr. Samake, if you are ready, please go ahead and let us hear your thoughts and reflections. Please unmute. Dr. Samake, go ahead.
OK. OK, merci à tous. Et merci à tous les présentateurs et orateurs pour ces brillantes présentations. Et par rapport à notre réflexion concernant ces résultats de la recherche, comme il a si bien dit, moi je travaille pour Action contre la faim au niveau du Mali. Et nous, au niveau du Mali et Action contre la faim, pour ce qui concerne ces résultats, nous sommes pratiquement d'avis avec ces résultats. Et je vais quand même donner nos impressions en fonction des différents articles, comme il a été détaillé 4 articles dans ces résultats. Pour ce qui concerne la première partie, le premier article, en se basant sur ce que nous constatons ici au Mali et sur notre expertise et notre expérience sur le terrain, nous pouvons témoigner que ces données vont dans le même sens, en s'appuyant sur les modifications des caractéristiques de la crise, comme on l'a constaté dans les documents, comme c'est le cas aussi au Mali, les changements du mode opératoire, on assiste maintenant au changement du mode opératoire où les groupes armés sont en train d'utiliser, si on peut dire, entre guillemets, la faim comme une arme de guerre, en brûlant les champs des populations, le fait de les pousser aussi à vendre certaines sources de revenus comme leur bétail. On sait que la crise a commencé surtout au nord et la plupart des communautés, ils sont des nomades où chaque ménage a à peu près quelques têtes ou des bétails, surtout pour les femmes, des petits ruminants où ils vendent en fonction des problèmes pour remédier à certaines dépenses comme les dépenses de la santé des enfants et même l'éducation et la nourriture parfois de la famille. Donc, ils sont en train de perdre ces revenus. Il y a également l'enclavement des villages qui s'est fait à la longueur de la journée en sabotant des voies, en coupant certains points de liaison, empêchant les communautés à accéder aux services de base. Donc, avant, c'était les forces armées régulières qui étaient surtout les cibles de ces groupes armés. Mais depuis un bon moment, on sent l'instrumentalisation de la communauté. Et la communauté est maintenant mise au centre de ce conflit, ce qui pose aussi des problèmes d'accès aux services de base, surtout pour la santé. Dans cet article également, pour réagir efficacement au changement, il a été question, il y a un passage qui parle d'une adaptation rapide et une capacité accrue à identifier les structures de gouvernance locales et les capacités de gouvernance spécifiques qui vont permettre la fourniture des services de santé. À ce niveau, nous dirons qu'effectivement, pour répondre à ces changements, il faut revoir le système de gouvernance, c'est vrai, mais il faut prendre aussi en compte tous les autres piliers du système de santé en mettant un accent particulier sur la participation communautaire, si on peut dire, qui peut être un septième pilier. Et pour aussi renforcer cette idée, il y a Action contre la faim, notre bureau régional Dakar a mené une évaluation de la résilience du système de santé face aux urgences sanitaires et nutritionnelles en 2018 au niveau de la région du Nord, plus précisément à Tombouctou et au Niger, au Mali. Et à travers ces résultats, il a été identifié que chaque pilier du système de santé subissait des effets combinés des pics de pathologie. Donc, il est nécessaire, c'est vrai, de revoir le système de gouvernance, mais il faut aussi prendre compte des autres piliers. C'est ce qu'on ajoute à ce niveau. Quelque part, toujours dans ce premier article, il fait mention des impératifs techniques d'une prestation de services plus perfectionnée et plus complète. Bon, à ce stade, pour nous, devant ces situations, notre manière, Action contre la faim, de faire, n'est pas de trouver un truc très perfectionné, si je peux dire, entre guillemets, qui risque d'être assez compliqué parfois, mais c'est de trouver aussi juste un système de santé qui soit résilient. Et pour cela, la meilleure réponse est de baser cette résilience sur un système communautaire. C'est ce que nous faisons actuellement pour faciliter l'accès aux soins. De plus en plus, nous développons plus d'actions, nous appuyons plus les services, les autorités sanitaires à mettre au devant ces approches communautaires identifiées selon les politiques nationales. Et quelque part, toujours dans l'article, il fait mention des impératifs techniques d'une prestation de services. Bon, ce que je venais de dire, de plus perfectionné. Donc, pour cela, nous disons que le premier article, oui, nous sommes tout à fait d'accord, nous nous voyons dans cet article, mais il va falloir renforcer la gouvernance avec les autres piliers et aussi de mettre au devant la participation communautaire, l'implication de la communauté à tous les stades. Pour ce qui concerne la deuxième partie, elle parle de l'augmentation des mouvements, et ce qui fait partie aussi de la réalité du terrain au niveau du Mali. La destruction des moyens d'existence et la détérioration des conditions de vie dont je viens d'expliquer plus haut, et ce qui augmente les risques de mortalité et de morbidité par la violence directe et par les effets. Donc, en parlant de l'augmentation des risques de mortalité et de morbidité, nous, à notre niveau, nous n'avons pas ici des données bien détaillées, mais nos arguments vont bien sûr dans ce sens. En se référant aux résultats de la dernière enquête démographique et de santé, EDS6, qui s'est déroulée en 2018, qui a été réalisée en 2018, globalement, on observe une baisse continue de la mortalité des enfants, notamment à partir de 2001. Et que le coefficient de mortalité a été estimé à 113 pour 1000 en 2001 et qui a passé à 54 pour 1000 en 2018. Donc, on dit qu'il y a là une diminution selon les chiffres. Durant la même période, le coefficient de mortalité infanto-juvénile a aussi diminué. Mais il faut signaler une sous-estimation, ce qui a été quand même lié à des sous-déclarations importantes de décès. Donc, on peut dire que quelque part, ça cache un peu cette réalité. Et cette sous-déclaration s'expliquait par l'insécurité qui prévoyait, surtout dans les lieux septentrionaux du pays où la crise était plus accentuée. Donc, toujours en 2018, selon les mêmes enquêtes, le pourcentage d'enfants ayant reçu tous les vaccins de base a légèrement diminué. Et cette diminution aussi a été expliquée par les problèmes d'accessibilité à certaines communautés, où la faible couverture a été rencontrée plus dans les régions du Nord. Donc, nous voyons ici également que, comme ils l'ont si bien dit, ça marque quand même ces problèmes d'accessibilité. Et comme ils l'ont si bien dit, tous ces facteurs ne peuvent que concourir vers une augmentation de la morbidité et par conséquent de la mortalité. Donc, nous pouvons dire également que oui, on est d'accord effectivement que la crise quand même a entraîné une augmentation de ces taux. Quelque part, même si on n'a pas les chiffres, mais les arguments vont vraiment en faveur de ceci. Et il a été quand même dit également que dans ces régions de conflit, seulement les communautés urbaines ont été touchées par cette enquête dans certaines régions. Donc, ces niveaux de mortalité qui ne reflètent pas la réalité qui prévaut dans ces localités. Oui?
Dr. Samake, thank you very much. I'm going to ask you to wrap up. And I'll say thank you very much for thank you very much for those reflections. And I know, apologies for having to cut you off. I know that you had more to say, but great for flagging a number of issues, including kind of the importance of resilience that's derived from the community and being able to find solutions by engaging meaningfully with the community, rather than always looking or trying to look for the perfect solution, and also for highlighting your experiences and thoughts on the need for better data collection. So thank you very much for that.
Voilà, alors, voici, je vais dire que... Voilà, voici quelques réflexions par rapport aux lacunes citées par les uns et les autres. Effectivement, alors, il parle effectivement de l'importance des données, notamment pour la planification, les plaidoyers auprès de l'État. Mais à ce niveau, il y a encore du manque au niveau des données annuelles. Et souvent, il y a des difficultés pour avoir certaines données, notamment avec certaines agences qui collectent des données. Et aussi, il y a un manque de données réelles, surtout dans les zones de conflit. C'est vrai qu'il y a l'EDS qui est là, mais dans l'EDS, ce n'est pas des données fragmentées. Le PRODES aussi manque de données dans les zones de conflit. Et en plus de ça aussi, il y a des données qui manquent surtout au niveau des équipements et des agents de santé sur le terrain, notamment dans la zone du Nord. Aussi, il y a des manques d'informations pour planifier les actions en faveur des enfants et des femmes enceintes. Ensuite, il y a aussi un problème de couverture universelle, en fait, des données qui a été évoqué beaucoup par Antonio, mais que je n'ai pas pu bien comprendre un peu son français, mais on peut redresser ça après. Ensuite, il y a Action contre la faim qui parle aussi de la représentativité des données. En fait, les données ne sont pas assez représentatives, notamment les cas de SMART, qui est une enquête sur, je pense bien, la malnutrition. Mais les données dans cette enquête, c'est au niveau des régions et non au niveau des districts. Alors que ce manque rend difficile l'intervention, souvent des interventions spécifiques. Donc, il y a des données macro, il y a des problèmes de complétude des données, il y a aussi des problèmes de partage des informations, surtout les données sur les évaluations que les partenaires font généralement. Donc, il y a des difficultés à ce niveau. Toujours au niveau des femmes et des enfants, il n'y a pas de données spécifiques. Et le coût aussi des enquêtes, notamment pour avoir des données désagrégées, apparemment, ce coût est assez excessif et ça demande beaucoup d'investissement. Et les partenaires ne sont pas toujours prêts à s'aventurer dans ce domaine. Alors, pour la coordination des réponses en santé, alors, il y a des lacunes à ce niveau, notamment l'insuffisance entre les cadres de coordination décentralisée, le manque d'articulation, l'absence de mémoire pour capitaliser les leçons apprises et les bonnes pratiques. Alors, il y a aussi une focalisation en fait du cadre de coordination sur les réponses et non sur l'anticipation. En fait, il y a beaucoup plus de réponses au niveau des cadres et non de l'anticipation. Il y a aussi une cacophonie entre les cadres de coordination. Et CBD rappelle aussi que vraiment le problème d'anticipation, c'est vrai, mais aussi pour les acteurs de terrain, c'est difficile aussi en fait de faire de l'anticipation parce que souvent ils sont chassés en fait du terrain. Il y a aussi un manque de centralisation des données des acteurs internationaux auprès des directions nationales de la santé. Par rapport au service de santé et toujours à la coordination des réponses humanitaires, qu'est-ce qui peut être fait? Alors, il y a des propositions de solutions qui sont élaborées, notamment des outils qui sont élaborés et qui doivent être renseignés. Et à titre d'exemple, il y a le Mali Kunafoni, qui est un outil élaboré et qui est disponible, mais malheureusement qui n'est pas renseigné. Et apparemment, cet outil-là est disponible au niveau de la DGS, au niveau de l'État du Mali, mais ce n'est pas renseigné. Alors, pour encore les prochaines étapes ou les options, c'est de mettre l'accent sur la remise à niveau pour mieux manipuler en fait les outils, renforcer les capacités des utilisateurs des données, renforcer le leadership de l'État en vue de mieux les responsabiliser en fait. Il y a effectivement aussi peut-être pour action, c'est-à-dire de partager les données, les leçons apprises avec l'État, à renforcer la coordination avec les humanitaires. toujours dans ce même ordre d'idée, il y a Madame la représentante de l'UNICEF au niveau de Dakar qui demande de renforcer en fait la résilience du système de santé, travailler sur tous les piliers et remettre les communautés au cœur des systèmes de santé pour avoir des soins de qualité et renforcer la digitalisation des données en intégrant la santé maternelle et infantile au Mali. Voilà, ça c'est quelques notes que j'ai ramassées au cours de l'intervention. Peut-être on pourra mieux les approfondir voilà, plus tard en fait, pour avoir un document assez limpide. Voilà. Merci. S'il y a des choses encore à ajouter, je peux les prendre et ajouter au fur et à mesure. Merci.
Merci bien, Dr. Samadiara. Je voudrais juste ajouter, si vous me permettez, quelques petits points pour compléter. Par rapport aux données non désagrégées au niveau district, il y a aussi, en dehors des enquêtes EDS et MIX qui sont réalisées périodiquement, les planificateurs ont besoin aussi des informations annuelles. Parce que EDS et MIX c'est fait de façon chaque 3 ans, chaque 5 ans. Mais en dehors de ça, il y a aussi des insuffisances dans les informations annuelles. Parce que chaque année, il y a une mise à jour des informations, ça permet de faciliter la planification. Par rapport à l'inexistence ou à l'insuffisance des données dans les zones de conflit, en fait, le fait aussi que les données les lieux sont inaccessibles. L'inaccessibilité de ces zones peut faire aussi que les données sont aussi inexistantes ou insuffisantes. Juste aussi par rapport aux différentes options proposées pour combler les lacunes, il y a aussi, lorsqu'une étude de recherche ou une évaluation est menée, s'il y a les données disponibles, l'État du Mali, l'État de la Direction nationale de la santé devrait jouer le rôle de leadership pour pouvoir proposer une dissémination des données pour permettre à chacun et à autres d'être au courant de ce qui a été fait, de ce qui existe réellement et quelles sont les dernières informations. Voici les quelques points que je voudrais ajouter par rapport à ce que mon collègue Samba vient de dire, sorti de notre discussion de groupe. Merci.
Thank you, Dr. Tunkara. Merci beaucoup. And Dr. Diarra as well. Thank you. Let us move on, if you don't mind. Samba, if you want to stop sharing your screen, and let's ask Professor Adebola, Professor Oramedegun, and your group. Isaac Olufadewa, I think you were taking notes. Can we please move on to your session? And I'll ask you to please, we need to keep it brief at this point so that we can also squeeze in our panel session. So please go ahead. Thank you.
Thank you very much. Isaac will be speaking on our.
Hello, everyone. So for our group, we talked about the gaps in evidence and the key evidence and guidance gaps, which we identified as access of healthcare workers to children and women for healthcare interventions. And we discovered that guidelines is needed on this. Data collection is a huge challenge. Innovative evaluation tools are needed for this. Government response in promoting health service delivery, tools needed to measure this. Adolescent data is non-existent, which has affected data collection on section on gender-based violence and response coordination. So we are looking at, if you can have tools and guidance on this. On the second part, which is looking at the key evidence and guidance gaps in respect to humanitarian health response coordination, we discovered that the quality of interagency and the gaps in quality of interagency and multi-stakeholder collaboration on the front line. And the guidance, it was discovered to be needed on this. We also discovered there's a security challenge between host community security agencies and humanitarian worker. And if we could have a guidance on this, it's going to be very great. Then we need tools to be able to measure the intersectionality between education and health, and data on qualified health workforce and quality facilities in conflict region is also needed. For the second question, we looked at the next steps to fill in the key evidence and guidance gaps in respect to health service delivery and humanitarian health response coordination. We had insightful next steps, such as the involvement of UN agencies and multilateral agencies to hold our governments accountable, development of governmental guidelines to guide key actors and agencies in humanitarian response, a multi-stakeholder forum or meeting or a coalition between humanitarian agencies, researchers, government institutions, and funders was going to be needed, and then flexible funding mechanism to improve humanitarian response by ensuring that these organizations are flexible with their programming, and then strengthening data collection analysis on available data to inform policies. Other key messages from our group talked about legislation needed to develop a bill to promote funding and coordinate resources to focus on this issue in conflict-affected regions, and strengthening local government, which is like the backbone of the primary government agency and district health systems in the region to promote actions and ensuring improved collaboration between government and humanitarian organization. So thank you very much. That's like what we had from our group.
Thank
so
you.
Okay.
Thank you, Isaac and Professor Adebola. That was great. That was very quick. I'm not sure if the translators will have picked up on everything, but fantastic. Thank you, Isaac. And then let's do some reporting from our final session from Dr. Lawanson and your team. I think it was Ronke who was going to.
Ronke will be doing that.
Great. Please go ahead.
Yes,
I think Isaac needs to shut down his close his window screen.
No, I think.
Thank you very much for
thank you.
The opportunity from our group. We talk about the need for good community entry and reaching out to community stakeholders, mapping out of the organizations who is doing what and what are they doing, the need for mobile clinic, and the need for sociocultural. There are sociocultural barriers that affect access to healthcare services in those regions, and what are those things that can be done to address those challenges. And there is need for sensitization from the community stakeholders. Then for the second part of the presentation, we look at the need for the challenges that humanitarian services face in giving services to those regions, and the need for the facilities to function properly, because even some of the available facilities are not functioning properly. Sometimes there will be facility, but there won't be anybody that will attend to those women when they get there. So because of that, they get discouraged to even access the facility. Then the second question is talking about filling evidence and guidance gap. We talk about the need for, there is always this, there is always need assessment before any intervention is carried out. And there is also, we talked about the need for multi-sectorial need assessment before any intervention. And we made mention of the need for emergency response, particularly in northeastern part of the country. And due to their dynamic change in climate, there is need for emergency response in those regions. I think those are the major points we discussed in the group. Thank you.
Thank you very much, Ronke and Dr. Lawanson as well. So that's great. We've had reporting from all three groups. It sounds like there was some very interesting and concrete discussion. I'm going to propose that we don't proceed with further plenary discussion now in the interest of time. But as I mentioned, that our group and our team behind the workshop, we can take these points and we will in fact help to synthesize them in our meeting report. So apologies for not being able to further discuss at the moment, but I hope you enjoyed and found the breakout groups useful.
This panel, let me start by introducing myself. I am Professor Isaac Olali Albert. I am a professor of security studies from the Department of Peace, Security and Humanitarian Studies, University of Ibadan. I am also the Dean, Faculty of Multidisciplinary Studies of the university. I was a former regional board chairman of the West African Network for Peace Building, and I'm a permanent member, a full member of Chatham House, London. Now, in this panel, I'll be working with 6 eminent panelists. The first is Ms. Sylvie Fouet. For more than 18 years serving UNICEF, she has worked with humanitarian and development context in Africa, the Middle East, Latin America, and the Caribbean region, and has been the UNICEF representative in Mali since August 2020. Prior to joining UNICEF, she worked for the European Commission in peace building and the Middle East peace process. We welcome you. The second person is Professor Adenike Grant.
Professor Albert, sorry for interrupting. Excuse me, sorry, it's Michelle. I just wanted to flag that, in fact, Ms. Fouet, Sylvie Fouet, just has advised recently that she's unable to join. In her place will be Dr. Fadiga Abdul, who is who's the Chief of Health for UNICEF in Mali. So sorry, okay. I think our messages haven't reached each other, but so that's representation from UNICEF in Mali by Dr. Fadiga. Okay,
I think that introduction is taken as your contribution to this panel. So my second panelist is Professor Adenike Grant, who is a retired professor of pediatrics and Dean, College of Medical Sciences of the University of Lagos. She has gained recognition as a strong advocate for the strengthening of healthcare systems for universal health coverage through the efficient delivery of primary health care before, during, and after her tenure as the Minister of Health in Nigeria. Currently, Professor Grant is the founder and board chairperson of the Adegran Child Foundation, through which organization she continues to advocate for sustained improvement in the health and welfare of vulnerable women and children, as well as for equity and universal coverage of vulnerable women and children. Coverage with quality and affordable health care. She's the chair of the board of trustees of the Nigerian Universal Health Coverage Action Network. Prof, you're welcome, man. Then the third panelist is Dr. Khalilu Muhammad. Khalilu Muhammad is a medical doctor and experienced public health professional, currently serving as a health specialist at the UNICEF Nigeria Country Office, providing technical and programmatic support to governments at national and subnational levels towards achieving universal health coverage. Dr. Muhammad's previous role include senior PHC system strengthening advisor to the Niger State government, UNICEF state team lead for the Polio Legacy Project, senior associate at the Clinton Health Access Initiative, and consultant to the National Primary Health Care Development Agency. As honorary technical advisor to the Nigeria Health Commissioners Forum on Health Policy, Planning and Sustainable Financing, Dr. Muhammad played a key role in designing Nigeria's basic health care provision fund implementation manual to guarantee a basic minimum package of health services to the poor and vulnerable. He sits on several technical committees and working groups on health policy, planning, financing, and performance management. We welcome Dr. Muhammad. Our fourth speaker is Mr. Adeyemo Androdikos. He has served the Nigerian Red Cross for more than 16 years in multiple disaster management and emergency operation roles. He's currently Director of Programs at the National Headquarters in Abuja. Then Ms. Cole, Koyi Simad represents the government of Canada as the first secretary for cooperation at the Canadian Embassy in Mali. Our sister, Ms. Bonis Zabulu, is not able to be with us, but we have an addition. Mr. Urakwa John is a deputy director and head micronutrient deficiency control unit of the Ministry of Health in Abuja. So I welcome all my panelists. What we are expected to do in this panel is to take another look at how to strengthen research, policy, and funding of health issues of women, of children, adolescents, and women. And we have been provided three focal questions. We have been asked to, each of us will be given 2 minutes to just have a general opening statement on the three focal questions. And what are these questions? How can we better bridge research and policy action to sustain and accelerate national and regional commitments to women and children's health in conflict-affected contexts? The second question is, how can we improve multi-stakeholder and multi-sectoral collaborations to deliver quality health services more effectively for conflict-affected women and children? And then the third, how can we ensure more consistent and more flexible funding and other resources to support quality health and other services for conflict-affected women and children in Nigeria and Mali? So what we will do, I will invite us one by one to just make a general opening statement on these three questions, and then later we would ask more pointed questions. Now, may I now invite okay, we have been told that Fred is not around. Okay, may I invite Professor Grant to open the floor, man. Over to you, Prof, man.
Thank you very much, Professor Isaac Olawale. I'm meeting you for the first time. I didn't realize that somebody like you actually exists in Nigeria with so much so much experience in military affairs, and particularly bridging the gap between military and academia. I think that is where we start from. The fact that usually in academia, we know nothing about the military. So thank you very much indeed. So how do we bridge research and policy action? Just what we have been discussing, the fact that research will have to be conducted with the consensus and participation of policymakers, so, because it is during that exercise that actually the bridging of the gap begins. And then it continues through dissemination of the reports and further validation of data. So it's a continuous process. Then how do we improve multi-stakeholder? Again, it has to start with first of all, the conduct of the research. The fact that needs assessment has to be conducted with a multi-stakeholder community, or their platform. Everybody has to be involved right from the onset. And how do we ensure consistent funding? This is where we get we use the result of our findings to get to those who are going to be responsible to fund the further practices, further interventions. And in doing this, we mustn't forget the policymakers and the private sector, the CSOs, everybody should be involved, and particularly the legislature. The legislature usually has to come to our, to our rescue by having a bill and legislative framework within which the funds can be mobilized and utilized.
Thank you, ma'am. Thank you so much, ma'am. Thank you, ma'am. May I now invite Dr. Khalilu Muhammad to address us. 2 minutes, ma'am. Sir.
Thank you, Prof. The two profs, and you're putting me in a difficult situation between two profs. But one is my great grand teacher, and because
grand teacher of all of us, indeed,
so
and a national icon.
Yeah, yeah. I think just to say that this is, for me, this is an important platform, and I will join Professor Grange in thanking Professor Isaac, and then of course Michelle and co for bringing this about. This kind of collaboration, I think, should be the first step towards bridging that evidence policy gap. So we've started walking the talk more like, and it's a positive thing. The other thing that I need to emphasize is the need, because we know that this town and gown discussion has been a long-standing one. And I think that one of the areas we need to begin to look at is we need to find a way of strengthening think tanks within academic institutions that have linkages with people in the field, the practitioners in the field, and so that what we do is not only evidence, but contextualized evidence. Most of the time when we find, and the insurgency in the North weeks has heightened this, is the lack of contextual evidence. And that also informs why some of our interventions yield suboptimal results, because they are based on frameworks and design that are not locally suitable. So I think continuing to promote that collaboration between think tank within academic institutions and people in the field, of course, with government serving as a broker, is very important. But the other issue around stakeholder coordination, which Prof has mentioned, also hinges around building the capacity of government to take the front seat. Because much as people want to support, the truth is that ultimately it is the host government that has the final responsibility to ensure that everybody is acting according to a common framework and then working towards a common vision. This is important because different actors will have different mandates based on different funding sources. But because the mandate of the government and its accountability framework is directly to the people, so it's important for us to find mechanisms to strengthen government to be able to, discharge that responsibility, what we call the responsibility of government as far as human rights is concerned. The host government must come in to coordinate everybody to ensure that everybody is singing from the same hymn book. And then finally, in terms of mobilization of resources, while I need to stress, for us to look inward in terms of mobilizing domestic resources, whether it is through the private sector and philanthropy, and here I mean we don't have a shortage of them in Nigeria. The Aliko Dangotes have recently taken interest, in a humanitarian setting, and they've been contributing. But I think one of the things that will help this to continue in a sustainable way will be issues around accountability and joint planning. We must plan jointly to ensure that there is efficiency in the use of resources. Thank you. I'll stop at this stage.
Thank you so much, Doc. Thank you so much. May I now invite Dr. Adeyema Adronikos of the Red Cross.
Thank you, Prof. Thank you so much, Prof.
Yes, sir.
It's a pleasure meeting with academics and reflecting with them and putting one thing or the other together. And thank you for all the organizations and people that have put these initiatives together. And our big mommy in the house, we are grateful for finding time at this very all time to be online with the young minds. Thank you so much, man. Now, collaboration, I would like to speak on the collaboration aspect. I would say it's intelligent sharing of information and a frank, constructive discussion of issues and possible possible course of actions and among independent organizations with a common purpose. Now, we started earlier on, and I would like to reiterate further that organizations need to communicate clear objectives in order to collaborate very well. And they also need to establish their mandate with the government agencies, because government, MDA, ministry, department, and agencies of government will be the one to initiate policies if it's not independently sponsored and is related to their mandate to liaise with the upper legislative or lower legislative chamber in order to put these things through. And it may not necessarily translate to law or act, but policy. And if we have to get it done, we need to move closer to MDAs and UN system. We don't need to play aloof. And also we need to provide regular briefings and timeliness and be self-sufficient to collaborate effectively. And it doesn't really mean that to collaborate, we must be money back like Liquid Dangote. Once we have the brains, we have the technical know-how, we can easily collaborate with relevant government, MDAs, and UN systems. So it will pay us well to collaborate, because if we don't collaborate with government and UN system, some of these findings will not be utilized. And if it is not utilized, it will be effort in futility. Thank you.
Thank you so much. Thank you so much, sir. Thank you so much. Let me invite Dr. Umarpa John to make his own statement.
Thank you very much, Prof.
Yes, sir.
I must extend my felicitation to Professor Grange. She was once my minister. So, Professor Grange, you're welcome, man. Nice to see you again. Well, looking at the topic of discussion, we see that conflict happens within a region. It happens within the country, within a district, within a location. And these locations where it happens, there is a government in place. And the most vulnerable in these locations are women and children, reaching them with no nutrition foods, access to social amenities, access to hygiene and water, and so many things. It's very, very critical for their survival. Therefore, if the government under which conflict is happening does not have the political will to encourage, implement, or a commitment that have to do with improving health and women, children, in that setting, there will be a problem. So there is need for government under which any conflict is happening to have that will to provide an enabling environment. Very, very important for partnership with international agencies and the domestic organizations that may respond to these women and children, bringing interventions closer to them in terms of health services or nutrition interventions or even social amenities for their survival. So that government must have the political way to assist, to cooperate, and to be neutral in that crisis. without which whatever thing that we do in that crisis, whatever response that we come up in that crisis will never work. And that crisis or conflict will prolong. That is why in humanitarian setting, in every crisis, there is this saying that if government have the will, the courage to stamp their feet and provide an open environment for all players to operate smoothly and provide security for health workers or players in the crisis, that crisis will not last. Thank you very much.
Thank you so much. Thank you so much.
Yes.
Thank you so much, sir. I think we need to take the person that replaced me, that Madam Silva. Do we have the person here? Michelle.
So Professor Albert, Dr. Fadiga is replacing Ms. Sylvie Fouet from UNICEF Mali.
Oh, okay, so we are fine now.
And we also still have Ms. Chloe Simard from the Government of Canada, who will also
okay,
also on
okay,
the panel.
okay.
Two people still.
Okay, sorry, ma'am. Okay, over to you, Madam Simard.
Okay.
I'm sorry for skipping your name.
My name is Abdul Gadiri Fadiga.
Sorry.
I'm taking place of Sylvie on this panel. So I would like to express in French. Et merci beaucoup à tous pour cette opportunité, à côté de ces, en tout cas, éminentes personnalités, pour prendre la parole sur ce sujet important qui nous interpelle tous. Le Mali, comme le Nigeria, nous savons tous, nous avons des situations similaires dans certaines localités. Et donc, du côté du Nigeria, du Mali plutôt, l'UNICEF travaille avec le gouvernement, mais également avec beaucoup de partenaires sur le terrain dans la mise en œuvre des programmes qui adressent les questions de la femme et de l'enfant. Et comme vous le savez, nous sommes dans le contexte, dans un triple contexte, développement, humanitaire, résilience. Donc, nous devons multiplier nos efforts pour pouvoir adresser la question de la femme et de l'enfant, surtout dans le domaine de la santé, dans ces différents contextes. Et nous utilisons des données pour pouvoir vraiment, comme je le disais dans le Breakout session, nous utilisons des données pour pouvoir renseigner nos planifications, mais également faire du plaidoyer auprès du gouvernement parce que, comme vous le savez, auprès du gouvernement, nous essayons de soutenir les mandats des enfants, pour l'UNICEF surtout, pour pouvoir atteindre, je peux dire par exemple les SDGs, mais également atteindre les résultats attendus et améliorer la santé des enfants et des femmes. Alors, mais il se trouve qu'au niveau du Mali principalement, il y a des insuffisances en matière de données qui puissent permettre en tout cas d'orienter l'action du gouvernement en matière de santé pour atteindre réellement les résultats que nous cherchons. Si on regarde beaucoup plus au Mali, les données qui sont disponibles sont des données qui sont collectées sur des périodes de 3 mois, de 3 ans, de 5 ans, à savoir l'EDS, à savoir les mix, à savoir les outils comme les MODA sur la pauvreté multidimensionnelle. Donc, on n'a pas un mécanisme qui permet de collecter les données annuellement et qui soit fiable, à part le système administratif qui est là, qui concerne par exemple le DHS2. Donc, nous pensons que ça, c'est un gap qu'il faut essayer de combler, et ce gap permet aujourd'hui d'orienter vraiment, d'adresser les questions du moment une fois qu'on a des informations qui sont à jour. Aujourd'hui, par exemple, nous sommes dans une situation où la situation sécuritaire s'est détériorée dans certaines localités où où c'était des zones paisibles dans Ségou, dans Sikasso, mais dans cette année, depuis l'année dernière, on a compris que la situation se détériore, mais on n'a aucune donnée dans ces localités sur la détérioration de ces situations parce que la collecte n'est pas instantanée. Et on sait aussi que, comme dans beaucoup de pays africains, la recherche est confrontée à certains défis. On a la non-priorisation, par exemple, de la recherche dans l'action gouvernementale. Je pense qu'il est important que chaque fois que une politique doit être émise, que ça soit basé sur des bases factuelles, sur des données probantes. Et ça permettrait beaucoup plus d'orienter l'action vers là où il y a les besoins. Nous avons aussi des centres de recherche au niveau du Mali, mais parfois qui manquent de ressources. Comme on le sait, la situation de conflit fait que mener des recherches au niveau du terrain devient très complexe, très cher aussi, et que parfois il n'y a pas de ressources suffisantes pour pouvoir atteindre. On le sait, il est plus facile de mener des recherches dans Bamako, dans Koulikoro, sur ceux qui sont aux alentours, mais pas facile dans les régions comme Gao. Merci à vous.
Thank you so much, man. I do know that the situation in Mali is as complicated as what we have here. Things are getting worse, but so thank you so much, man. Do we invite Madame Simad? Madame Simad.
Oui, bonjour. Tout d'abord, merci beaucoup pour cette invitation. Donc, c'est un honneur également pour moi d'être ici au nom du chef de la coopération de l'ambassade du Canada au Mali. Donc, peut-être juste quelques petites réflexions d'entrée de jeu. Effectivement, le manque de données précises dans les zones de conflit est un défi qui a été abordé, je pense, tout au long de la session aujourd'hui et qui vient d'être mentionné par mon collègue, le docteur Fadiga de l'UNICEF. Et je pense que nous, de notre perspective de donneurs, de bailleurs de fonds, une des manières de composer avec cette lacune serait de permettre davantage de flexibilité dans la mise en œuvre des initiatives afin que celles-ci puissent être adaptées en fonction des apprentissages en temps réel grâce aux données qu'elles collectent au cours de leur mise en œuvre. Mais un autre enjeu aussi, c'est que même lorsque nous avons justement des données sur des approches qui sont porteuses pour améliorer la qualité des soins de santé pour les femmes et les enfants qui sont collectés donc, dans le cadre de nos initiatives, une appropriation par la partie nationale est absolument nécessaire pour permettre de les mettre à l'échelle et donc de vraiment pleinement les exploiter. Il est également essentiel donc, de les diffuser auprès des autres intervenants pour que ces approches puissent continuer à être répliquées et à être testées pour qu'on ait plus d'informations justement sur leur efficacité. Dans cette optique de diffusion, en fait, il ne s'agit pas, à mon avis, de réinventer la roue, mais plutôt de tirer profit de la multitude de groupes de coordination qui sont déjà existants au Mali. Donc, il faut capitaliser sur ces structures et voir comment on peut les améliorer, notamment, je pense, en accueillant des intervenants plus variés, donc notamment des intervenants du milieu de la recherche qui sont souvent absents des groupes de coordination. On peut également capitaliser sur des meilleurs outils de partage et de gestion de l'information. Et c'est vrai au niveau national, mais également au niveau décentralisé, où les mécanismes ne sont pas toujours aussi efficaces, les cadres de coordination ne sont pas toujours aussi efficaces d'une région à l'autre. Et vraiment, pour maximiser en fait ce qu'on peut tirer de ces cadres de coordination-là, on a absolument besoin d'une appropriation et d'un leadership par le gouvernement malien. Finalement, je voulais peut-être juste toucher rapidement au financement. Et donc, je pense qu'en ce qui concerne le financement, notre avis, et je pense que ça a été d'ailleurs mentionné, c'est vraiment l'importance de s'aligner aux plans nationaux et qui sont développés donc par les gouvernements afin d'assurer justement une meilleure planification et une meilleure prévisibilité du financement des activités en santé. Et d'avoir aussi justement une meilleure coordination entre les différents bailleurs de fonds. D'ailleurs, la COVID a démontré que les bailleurs de fonds pouvaient être plus flexibles. Par exemple, juste pour terminer, le Canada a réussi en 2020 à approuver pour 39 millions de dollars canadiens pour des nouveaux projets ou des nouvelles composantes de projets liés à la COVID-19 au Mali. Et puis, je pense qu'il y a vraiment des leçons qu'on peut tirer de cette situation pour améliorer nos processus de financement. Et justement, c'est là-dessus qu'on travaille. Merci.
Thank you. Thank you so much. Thank you so much. Thank you so much. Let me throw more pebbles in the pool. And so that when we begin to answer some of the questions that we'll be discussing, we'll rake up all the necessary information that we need to engage in this forum. The first one is that I want to remind us that this project should be at the heart of the two nations, Nigeria and Mali. One, women build nations. Women constitute the second wing by which any society can fly. So if women are not healthy, then it is difficult for us to expect Nigeria or Mali to be a better nation. So the project we're discussing here is not just ordinary project. It is a project that will shape the future of the two countries. The second one is that adolescents are children, are future leaders. They are the leaders, they are the owners of Mali and Nigeria. And therefore, if they are not healthy, then there is no Mali, there is no Nigeria. I want to start with that. Now, we have made the point that in the two countries, we do not have good data. We do not have quality data. Now, can we quickly point at the pathway that we think the BRANCH project has provided on how to get good data? So let me put that question to my senior colleague, Professor Greg, if she's still on the line, if she's still with us, because she's been working in this field for a very long time. What are the good lessons that we can take forward from the reports that we have received so far from the BRANCH project? Prof, man. Okay, if she's not on the line,
yeah, I am here. I am here.
Okay, man. Thank you, man.
Yes.
Thank you, man.
Thank you. Let me start by redeeming myself by congratulating Michelle and the team for providing us with these research findings. You know, it's not easy. I know that, and we are very grateful to you because it really it will help us to kick off a very important area of discourse among us. Until now, I don't know about all of you, but very little has been discussed about the healthcare delivery system in conflict-affected areas. In Nigeria, I know that for sure. I don't know about Mali, but in Nigeria, there's been a great silence about it. We really have not been talking about it. It's very important that we talk about it for several reasons. One of which is the fact that generally healthcare delivery has not been effective in Nigeria. You know, we have actually lost the plot with healthcare delivery in Nigeria. So this may help us to revive the conversation, you know, because, you know, if you, I would like to say that, you know, if you bring something that is different on the scene with regards to some problem that has been going on for years and years and years, we may actually be able to wake up interest of the various stakeholders, including the government. So what can we take home from their research? I believe that the first thing is that they have shown us that it is possible to do research even where things seem to be impossible. You know, because when you talk about insurgency, you say, we are not going to that area at all, you know. We can't reach it and all that. But look at the way they have compartmentalized what can be attained, what kind of data can be got from the 3 different type of areas. So I forget, you know, how you, I think I can, if I can refer to my notes, the fact that you have the core area which cannot be reached at all, then the ones that are close to it, but you can reach with certain interventions, and then the ones that are further from it and you can reach with more interventions. I believe that is a brilliant idea that will help us not to be intimidated by, you know, these by the dangers of going into those areas. You know, so I want to congratulate.
Thank you so much. Thank you so much, ma'am.
Yes.
Thank you so much, ma'am. I think the point we are making is that the position of the branch project is clement, is good. In fact, we can score it more than 80%. And we have suggested some areas that, where the gaps to be filled. So I want one of us to respond to this question. How can we improve relationships and partnership between academics, national NGOs and CSOs, international NGOs and CSOs, donors, government and security agencies to work together? Because I think the branch project will want to follow up on this. And I think our colleagues from UNICEF should advise us on this, because you have the experience of engaging in multi-stakeholder projects.
Yeah. Okay, Prof, if I could maybe just go at it. Thank you for that question. I think just briefly aligning with Prof in terms of the branch project having charted the pathway for this hitherto neglected area of work, which is around synthesizing locally relevant evidence. I think in terms of how do we take this forward, bringing together all these different entities you mentioned, I think the UN has a peculiar advantage because for two basic reasons. Yeah, given our convening capacity, of course, working closely with the host government, the UN should be an avenue where we can look forward to champion this process, one. And secondly, because one of the issues you mentioned, Prof, earlier on is around how restricted some of this funding that go to humanitarian settings can be. In terms of these are envelope funds, there's limited flexibility around what you can do with it. Again, the UN has a peculiar advantage here because UN has some kind of flexible funding arrangement, that is not straight-jacketed along that line. Because of these two key reasons, I think involving the UN more closely and then working with UN, given its convening capacity, but also the flexibility of its funding arrangement, could be a starting point. And I want to just to draw your attention to the fact that this is an area that already University of Ibadan generally, beyond this, is already taking the lead. The University of Ibadan Research Foundation, I see as a think tank, which we've worked with the University of Ibadan Research Foundation in the last 2 years. And I see that as a platform, not only to promote this town and gown relationship, but also because that experience is already evolving around developing that cooperative agreement, especially between UN agencies and the University of Ibadan, but also using that as a platform to bring in other civil society organizations under one umbrella, using this flexible funding arrangement to be able to take forward this kind of, operations research, and then see also using the mechanism of the United Nations, especially our close collaboration with government, to see that the findings are also brought back to inform how policies are generated around, reaching the vulnerable women, but also shaping how funding is allocated, even, to address some of these key issues.
Thank you so much. Thank you so much. In addition to the University of Ibadan Research Foundation, I think TEDFund has also established, has constituted 13 R&D committees, research and development, and one of the committees is on One Health. And I was told just 2 weeks ago that the One Health project will soon be having a community engagement. And I think Mohammed should do a follow-up and, if possible, invite other stakeholders to that meeting. I am already working with the Defense and Security Committee. Now, one last question that I think we cannot run away from, answering before we conclude this engagement is, what are the most urgent next steps or priorities on this project? What do you think, if we have to advise the branch project on the next steps to take, what should these steps be? It's a question for all of us. Yes.
I think, yeah, I think the first, what I think will be the first next step here will be to ensure that this report finds, reaches greater audience, by which I think there should be a deliberate effort to disseminate widely, including even beyond virtual meetings. There are platforms right now. The National Council on Health is holding. This would have been a beautiful opportunity to just present the key findings and takeaway messages from this project, and then also using that mechanism, to also get into the government policy process. But I think for me, one of the most important is to ensure that this good message does not stop at this stage, that it goes, it should go, if I use the tech world language, it should go viral. If it goes viral, and I think I can take it up from there.
Yes. Thank you so much, Muhammad. I think as I listen to you and all others, I'd like to say this is a well-organized meeting, quality participation, because listening to all of us, we're all well-informed people. We are not too many, but everybody that is on this platform has something concrete to contribute to the project. And I like to advise Muhammad and Prof and Professor Jegede that this conversation must continue beyond this platform. I don't want to actually summarize all that we have said. We are all good listeners. We all contributed to the discourse. And I think what one would say as a way of signing out is to encourage those behind this project to say you have started well, but we don't want this to be a still bat. We want to see the second stage of this project. I mean, we want to take it to the next level, because you have opened up a very big vista of opportunity for us to engage some of these issues. By next week, I'll be making a presentation, a virtual presentation at Chatham House, and I'll be discussing Nigeria and Mali. And some of the issues we have discussed actually is showing, some of these issues are showing us that probably we are just, rubbing the surface of the problem. We're always talking about military operations, but there are other operations that we should address ourselves to. And I think these are some of the issues that we have raked up here today. We have just 2-3 minutes left. So I don't know if Michelle would now allow us to listen to Buta as well as Adebayo. Michelle.
Please, yeah, let's have, thanks, Professor Abbott. Let's have Mr. Adebayo comment, and then Zulfi and Professor Grange, if you want to add some final comments. And then I think we'll hand over to Professor Jegede to formally close us out.
Okay, over to you.
Thank you.
Thanks.
So, Mr. Adebayo.
Okay. Thank you so much, Professor Isaac Olale and Chair, for giving me this ample opportunity. I would like to, based on the last question posed by Professor Isaac, I would like to contribute that the initiative need to embark on HD, humanitarian diplomacy, at Geneva level and New York. We have what we call ring-fencing financing, that major issues, major emergencies in the world seem to ring off funding appeal for the Northeast and other areas in Nigeria and Mali. For instance, this very month, from August, OCHA launched a piece, $600 million for UN systems, and it has been reached 100%. I hardly believe whether Northeast API has been reached 100%, except maybe from the beginning. So if Geneva being the humanitarian headquarters and New York being the UN headquarters, so we need to carry out humanitarian diplomacy with all these findings. Thank you.
Thank you so much.
Thank you. I will just make a brief comment and then just leave it for you to summarize and to hear from Nikki. So I've been a fly on the wall and listening to everything. I would say one priority that we have in the region, particularly in Africa at this time, is to use the entire nexus of conflict, humanitarian, and response to fill the gap around epidemiology that is currently of huge global importance. The least information that we have on COVID is from conflict zones, is from displaced population and emergencies. And this is giving perhaps a false sense of all being well in those areas because there is no information. And now as we grapple with both vaccination strategies, diagnostics, and getting burden estimates to this pandemic response, this is an opportunity to use available resources for COVID epidemiology to strengthen information systems in complex areas and some of those zones. So I'd make that as a fervent plea because this is a matter of great priority. Thank you.
Thank you.
Okay.
Thank you.
Rothman.
Yes, mine is very brief. Just to find out, how can I get speakers to address my CSO, which is NUCAN? It's an intersectoral civil society organization, and we're having our annual general meeting on the 10th of December. I would like Professor Albert there and possibly another speaker from Branch to virtual, of course, you know, to address us, because they have no idea at all about what has been going on in these conflict affected areas. Thank you. So we're going viral.
We can, on behalf of Branch, Professor Grange, we can definitely follow up with you to see who might be able to join from the consortium. Thank you for the invitation. Thanks. And now to Professor Jegede to final comments.
I think it has been a long day. Thank you very much for making the day very successful one. I want to use this opportunity to appreciate our eminent panelists, especially Professor Grange, who despite retirement, is not tired. Each time we call upon her, she's also always with us. We thank you very much. Thank you very much for giving us your time. Bayo, you have been a wonderful person since the time I contacted you. You have always been exchanging communication. We thank Dr. John Brook Akpa, who, despite the
Professor Jegede, sorry, excuse me. You may want to turn off your video.
Joined us at this meeting. Really appreciate Professor Patricia Donley. We really appreciate you because all the while we tried to get in touch, but we didn't know that we are outside the country. Okay. We appreciate you for joining us. We thank our partners from the CPs providing resources for this program.
I think we may have lost Professor Jegede. So that's unfortunate, just in the final couple of minutes, but we made it through 3.5 hours, so that's fantastic.
The network is bad. So we thank you very much for the engagement, and we move forward from this level. All the recommendations we will take into consideration, and work with Canada group to make sure that this conversation does not stop at this level. So the next things that we're going to do, we get in touch with you later. Thank you very much for coming. So over to you, Michelle.
That's it. On behalf of Branch, thanks very much, everybody, and especially to our colleagues at the University of Ibadan, Professor Jegede and Professor Adebola, and our colleague, Dr. Isaac, and to all of you. It's been really, really great, and please stay tuned for the meeting report that we'll share with you, and looking forward to further discussion on next steps and other opportunities. Thanks very much, everybody.